Our team, welcome back to Plastic Surgery Untold, the greatest podcast in the world, as voted by us. We got some very, very special guests today. Today we are talking about Brazilian butt lift, which I know what you're thinking. We've talked about this before, but there's been some new things that we really want to share, including the ultrasound. This is one of the things that I think has been in the news. There's some recent statements for those of you that live in Florida and listen. And then now, as recent as just about a couple days ago, from the American Society of Plastic Surgeons and the American Aesthetic Society of Plastic Surgeons on ultrasound guided BBLs, which, if you follow us on Instagram, shame if you don't, we've already been doing for a long time, but we're going to discuss why we do it, why this is a thing, and maybe whether it should be a thing. But before we do that, let's get to all of our guests. As you guys know, Celebrity Anesthesia, what's going on, sir? Long time no see. Still
What's
looking
up?
fine.
Oh, thank you. I need to pay you a little visit, man. I saw the other day in the mirror. I looked in and I was like, wait a second, my forehead's moving. I look 15 years older than I should. So I need to pay you a little visit in the office. But yeah, man, good to be back. I'm glad we're back in the studio again. It's been a little while, so excited to jump into this topic. As you know, ultrasound is near and dear to my heart. I like seeing you guys using it in your applications, but it was cool to see kind of the evolution of ultrasound in my training and now how it's creeping into different avenues in healthcare. Very cool to see. I think it just increases safety margin kind of overall. So excited to talk about it.
And we'll get into that because it used to be for a lot of things, even in anesthesia, that
Oh, yeah.
people just did stuff by anatomical landmarks, things like that, which definitely have merit. But that is not a new thing in your world.
Oh, not at all. And I always tell patients when I'm going in to do a nerve block or, we're putting in a line, I always tell them this is kind of like an extra set of superpowers. I can see through your skin. They think that's pretty cool. So we'll chat about that.
And we're kind of like superheroes, so it makes sense.
That's exactly right. That's exactly right.
Speaking of superheroes, Dr. Weinfeld, what's going on?
Well, not a whole lot. Kids are back in school. That happened on Wednesday, so that's exciting to see them be able to progress. And I'm just really excited about this particular topic because it's really one in which we're going to be speaking 100% about safety, and it's going to help future patients out there understand the benefits of seeking someone who has had a full experience of training in a plastic surgery residency. And that's kind of a little bit of a cliffhanger. We'll get back to that in a minute.
And then we got some new guests. Would you like to introduce yourself? Let everybody know kind of where you are. Those of you who've been following already know, but those of you listening to our podcast and maybe have not seen on Instagram, little intro here.
Yeah, super excited to be here. Thank you for inviting me to be part of this podcast today. I am Chris Mickliffe, one of the newest additions here to Austin Plastic Surgeon, San Antonio. Super excited that now we're a little over 2 weeks out from opening up that office. Anyway, I am a plastic and reconstructive surgeon, primarily out of San Antonio. I do live in San Antonio. 50% of my time I do work at Brooke Army Medical Center. And the other 50% of the time, I'm here with Austin Plastic Surgeon.
And it's really cool because your background and when Dr. Weinfeld and I were meeting you, it was really neat because you've had the challenges of some very complex surgeries. You've also had the experience of doing a lot of aesthetic surgeries over the last year and a half in San Antonio. So, new to Austin Plastic Surgeon, not new to San Antonio.
That's right.
Not new to the world of aesthetics or complex procedures.
That's correct, yeah.
So super exciting for everybody. And then our next guest, and this is now making his debut with us and starting in like T-minus, almost 9 days?
About that, yep.
Okay.
About that, yep. I'm Sean Arredondo. I'm a plastic surgeon now, starting with Austin Plastic Surgeon September 1st. So
Awesome.
All right.
real excited. We're getting all the paperwork done so I can hit the ground running, getting all familiar with the office, with the staff, and it's been a great so far. I can't wait.
And sort of like Chris, again, new to our practice, not new to plastic surgery. You actually, we actually started residency about only 1 or 2 years apart, but you did a lot of interesting stuff over that time, including research, general surgery, which I think is priceless. We always tell new grads when they're coming out, and even our nurses, other people, that getting some critical care experience is priceless because I feel like it just helps you manage complex and difficult situations. And so maybe elaborate just for a minute or two.
Oh, yeah. Well, general surgery training was in Dallas, and we dealt with all sorts of gunshots, car accidents, putting in lines. The ultrasound was my best friend in trauma.
Oh, yeah.
That got him out of so many sticky situations and helped me even diagnose patients with problems that were wrong before we had to even make a single cut. And so any chance I get to bring my past to my future and kind of help augment the practice, I think is an exciting time. And so I'm really excited to see ultrasound just exploding across all of medicine, but now plastic surgery too. It's fantastic.
And I think this has been the growth of the practice and some new fabulous additions. I think it's been great for Dr. Weinfeldheim because it's all really given us all a chance to really hone in on the things that we love to do. I think that, it also makes us feel like, we each have a specialty that we can own and really develop and really give that care to our patients, which is ultimately a benefit for them. And then
It is,
the nice thing about the multiple locations is the state of Texas is a huge state, as most of us know. And people are traveling endless amounts to see Dr. Weinfeld, and now they don't have to travel from all over. And so it's really nice. And then I think people need to realize we're one big family. And so, the nice thing too is there's always someone around to help them, whether, whoever operated on them. And so the nice thing is we're always there to take care of them.
Yeah, we're simply an extension of each other at this point.
Right. We're in it for the patients.
Yep.
Let's do this. Let's jump into ultrasound guided BBL. As we talked about, we've done this before. And, one of the biggest things that's been out there is the safety of BBLs, and you guys feel free to jump in at any time. But I think most of us, for who don't know, let me give you the 2-minute recap. Way back when Brazilian butt lift came out, and it was, I would say that it's one of the relatively new procedures because people that were a little bit more gray-haired senior probably didn't train doing them. And there's a lot of people in practice who this wasn't a thing when they were in residency training. And unfortunately, I think some people were doing this maybe without proper training. And that's what you guys had alluded to just a moment ago. And there used to be, when fat transfer first came out, and there is some merit to this, that people were purposely injecting fat into the muscle, and the idea was that it was a better vascular supply. There was going to be more fat take per se. And we later learned, especially in the buttock where there's some very large veins, there's some pressure differentials and some other things, that this was predisposing people to the fat getting into the bloodstream. There's some really great studies that have shown that if you can keep the fat out of the muscle, it's becoming an extremely safe procedure when done well. So, and some of the tricks that we use to do that is large bore cannulas, positioning of the patient, staying in a superficial plane, cannulas that don't bend, these kind of exploding tip cannulas. So there's lots of things, but we're still always dependent on anatomy, positioning, patient feedback. Travis and I would do things where we keep the patient's muscles able to reflex. So if we touch them, we would get feedback and be able to do that. I think the ultrasound has taken us to a new level where we're able to see that. So everything that we think we're in practice doing, we can actually verify real time while we're doing that.
Right.
Dr. Weinfeld, some thoughts on that? I know I'm rambling
Yeah,
here.
absolutely. No, you touched upon some really
You
important
never.
issues.
Yeah.
You touched upon some really important issues, and this is, when you asked me to give a brief intro, where I thought it was important to highlight having a fully trained plastic surgeon to be able to discuss this with patients and talk about safety, think about safety in the procedure. And one of the things that we know from our work as reconstructive surgeons is that there are these massive veins that come off just on each side of the sacrum, so the tailbone, that go into the muscles of the buttocks. I mean, they can be as large bore as our pinky or thumb, even, Travis says. And so, or maybe he was giving me a thumbs up, like,
No.
you're right. Yeah, yeah.
And
And
I
so
mean, take that however you want. I've got a small thumb, but
and so they go into those go into the muscle. In addition to that, they're in a relative negative pressure. So there's almost a little bit of suction with that. So all you need to do is get a little bit of fat into the muscle relatively close to those veins, and perhaps have with a cannula a slight injury to that vein for it to suck up fat and get into our vascular system, where it can wreak havoc on our lungs, our brain. It kind of depends on the anatomy within our heart and our chest, and But anyway, that's where understanding that and really stepping back, understanding the anatomy, the physiology of our muscle and our vascular system helps us really understand why it's so much safer to be on the outside of the fascia. And what does the ultrasound do? It helps us understand that we're on the outside of the fascia as we're injecting fat. So,
and when I'm using ultrasound on patients for nerve blocks and for putting in line stuff, I basically talk to them about this idea that I understand the anatomy just like you guys do, and it's knowing the anatomy inside and out, but it is one extra level of risk mitigation. And again, the risk is super low of that fat injection into the vascular supply. But this just helps one more level to mitigate that risk and to reduce the risk of,
Right.
of
Who
an
wouldn't
injury
want to
like
see
that.
what they're doing in real time
That's
as you're doing it?
Exactly.
And some of the things, it's not that plastic surgeons or people didn't want to do this in the past. I think there's definitely been some big technology upgrades that has made this doable. Like everything else, anyone who's a little bit older remembers the Zach Morris phone. That weighed like a true brick, and so it was really cumbersome and really hard to use. I think the technology of a small ultrasound, which is actually the size of most of our iPhones now,
Right.
which Bluetooth to an iPad, makes this doable because of the motion and the sterility and those type of things. So I think technology has caught up where we can do this effectively. We also don't want the surgeries to last endlessly for you either. And so I think that's a big thing. But to Dr. Weinfeld's point, and maybe one of you guys can jump into it, I mean, a lot of this stemmed from Florida, where there was a large collection of these. Fortunately, and I'm knocking on wood here, we've never had this at our practice. This has not been a issue here in Austin, Texas. But, just because we haven't had an issue doesn't mean we don't want to do the best practices and don't want to continue to make things safer and better, when the technology's out there.
Yeah, I mean, what's happening in Florida is certainly, significant concern to the entire community. And, this is a multifactorial issue, of course. In Florida, we're seeing not only is this happening to plastic surgeons, but people that are not actually plastic surgeons are, committing these tragedies, unfortunately. And, one of the biggest problems I find is lack of education on the patient's behalf to who they're allowing to operate on them.
Which is some of the point that I think Dr. Weinfeld was trying to say in a very PC way.
So,
As plastic surgeons, we've done dissections for our reconstructive patients. We've taken gluteal fat and used it to reconstruct other areas. So exactly what you're talking about. Large bore veins, as soon as you hit the muscle, all of a sudden it's a spider web of veins.
That's right.
And so, just our experience shows us that's a dangerous plane to be in. So we know to stay away from it.
And there's this conscious mindset that like, hey, this is important. We understand, what can happen. And I think having that, I don't know if fear is the right word, but at least the concern of this.
Yeah.
And so it's always on the back of our mind. And that way we're making a conscious effort to
be safe.
be safe about this.
The healthy respect for the procedure
Ooh, I
and
like
the
that.
patient that's there.
Yeah, that's
I,
nice.
I was just about to call it a healthy fear.
Yeah.
It's always in the back of my mind with that kind of stuff. Things that are very, very low frequency and low, low occurrence numbers. Those things still stay in the back of my mind, and you got to have that healthy level of anxiety when you're doing any type of procedure on somebody.
The cool thing about the ultrasound too, and you guys, this doesn't get rid of all the other things that we do from a safety standpoint. With BBLs, we still give people antibiotics at the time of surgery. We send people home with antibiotics. We still wash the fat with antibiotics. We still use our large bore cannulas.
Yeah.
We still do the positioning and patient checks with the anesthesia team in terms of those things. This is just one extra step
That's just
we're
another
taking.
layer.
Mm-hmm.
Yeah.
See, would you mind talking to us a little bit? Because when we were operating together, it was great because we were able to discuss a little bit of the different layers of the fat, layers of fat in the buttock that I think we underappreciated in the past, and to some degree because we knew anatomically they were there, but wasn't a great way to treat and isolate them.
Yeah, absolutely. So, with the increase in technology that we've seen in the ultrasound, it really allows us to truly define, the different layers of the buttock, superficial and the deep layers of fat and the fascia and muscle. And in the past, we found ourselves, when we were doing these BBLs, really to be safe, we would use our tactile response and really try to keep that cannula very superficial. We really never.
I always wanted to feel the cannula, and
you
people
always
would
wanted to
comment
feel
on our
the cannula. That's
they
right,
would comment on our Instagrams that they could see some of the fat very
Rippling,
super rippling because and be like, did it on purpose because then I know I'm very superficial.
That's right.
But like you're saying, now we have some options.
Yeah. So now with these new options, with our ability to implement ultrasound, now we really can take and fill not only the superficial layer completely, but we can also fill that deep fat layer all the way down to the level of the fascia. That allows us to get more volume, better shape and contour, and what everybody really wants, projection.
And I think projection is always the hardest part with any BBL and any surgery like this. And so it's really nice that we can tailor some of this. And as you guys know, we do a lot of stuff with cellulite, so it's nice to be able to evaluate some of these different layers and how we're treating that.
That's right.
Wait, Dr. Weinfeld, what do you think in terms of the ultrasound and result stuff? I mean, it's going to be interesting over time to see how this plays out long term, for patients. My gut feeling is that people are going to get more fat retention because, as we all know, part of the reason people went into the muscle was to have those good supplies. Now we're hitting these different spaces. We can still put either the same or more volume, but in different spaces around good tissue.
Yeah. Well, I think it's helpful to understand what the definition of a graft is. We're talking about fat grafting. And so you want all of those fat cells that you're injecting to be reasonably surrounded by the buttock fat natural blood supply. And if you confine yourself, as you guys have been talking about, only to the superficial layer in the past because you didn't have ultrasound to confirm you weren't in the muscle and you're just doing that to maintain safety, you're really restricting the amount of blood supply that you might be able to get around each quantity of fat that you inject. But if you can safely expand the amount of depth that you're placing fat, knowing that you're not going into the muscle, you have a larger field, a larger, more fertile field into which to plant the seeds being the fat that you're grafting there from other parts of the body.
Mm-hmm.
So I think, as you said, it's going to really enhance results because you can get better fat retention, but also because you're injecting multiple different layers, you're really creating almost a foundation and then a first layer, a second layer, a third layer of a house really to push out and expand and to increase the size of that house, the height of that house.
Mm-hmm.
And I bet even over time you could follow how much you're putting in there and see how much retention you get.
Yeah.
Well, thank you for sharing our
Yeah.
current
Study.
research project with the world, but it's definitely something
There you go.
that we.
Have you guys thought about that?
But it's definitely something that we're actively working on because one of the big questions that we get, and we want to be transparent with people, but it's hard because the limit of we actually have. There's actually only one paper out there, and it measures some different stuff. But we want to look at how much projection, because now we can measure people pre-op, measure them immediately after, measure them 6 months later, so we can give you true numbers. Like, hey, on average, people increase by a centimeter projection or whatever it would be at that time. And then we're also looking at how does pre-treating people with cellulite, so obviously there's the immediate and then there's the long-term, because obviously the more information we can give patients about what to expect
better.
from their surgery, it's hard. I don't know how you guys feel, but imaging works great for breasts. I think it works great for nose. Dr. Weinfeld, you can jump in with that. But with lipo body contouring, it's much harder because there's a lot of factors we can't control in terms of skin retraction, shaping, those type of things.
That's right.
Yeah, no, agreed. Imaging can be very helpful to help patients to study what we're doing and to learn from it, but also to help patients understand, the distance that they've traveled in their surgery, and it really helps improve satisfaction without a doubt.
Mm-hmm.
Right.
What do you guys think? In my mind, I feel like the nice thing and the thing I've loved about the ultrasound is that I also feel like we can tailor stuff more to each person. Because in the past, we're so worried about being superficial, putting in enough. Now I feel like we can target specific areas that bother people. There's some areas of the butt that were always considered like the danger zone, so we're very cautious with that. I feel like now we can actually visualize and know what we're doing with a much more higher level of precision and tailor some stuff. You think that's true?
Yeah, I think so. I mean, when in the past when we were doing BBLs, based simply on tactile response, we were always just trying to be safe, staying out of those danger zones. To some extent, not getting the maximal response or contour that we would like to have gotten. But now with ultrasound, I think we can absolutely target those areas, target those danger zones, because you're under direct visualization at that point. You can see the vascular supply in the areas of concern. And so as long as you stay superficial to those and above the fascia, then I think it's fine.
Donald would like this, but it almost reminds me of putting in a cheat code on a video game. It's like you get that little extra bump of confidence. You've got a little bit of extra, wiggle room in there, and adds some, and adds definitely a lot to what you can do.
And then what do you guys think about, because some of the pushback I've gotten as I've sent this out to the Austin Society of Plastic Surgeons is that the time is going to just make these surgeries endlessly long. And I'd love to hear your guys' experience, but there's obviously a little bit of a learning curve, and some of it's teaching your team and staff. But I feel like once we've kind of gotten going, it really hasn't added much time. And I want to get everyone else's thoughts on
And
it.
I think there's a very simple answer to that, and that is that safety should lead first. If we as a society and as practitioners really believe that this is the safest way to do that, that needs to be the priority. And then we have to shape and mold everything we do around that. And so for someone who perhaps is less experienced and may take longer to do it with the ultrasound, maybe the safest thing to do is to break it up into 2 procedures. No patient wants to do that. No surgeon wants to do that. But if the patient and the doctor have a good connection, they want to stick together, but they want to stay safe, let safety lead first. Use the ultrasound and worry about the duration of the surgery afterwards.
That's a great point.
And I think also, like you said, with a little bit of experience, it's not going to add time. I know you'd be willing to have people come and observe you and, figure out how to do it efficiently. Did I just obligate you to say?
No.
The Johnny Franco School of Ultrasound. Come on now.
No, it's funny. I was actually going to offer at our Austin Society, and there's some great webinar stuff. It's funny because we've actually been talking with some of the aesthetic and other society stuff to do this. Dr. Nykiel and I teach a BBL course, and we're actually implementing this as part of that course. And we're going to do about a 30-minute session on just this, And so there's also some other paid courses, but sort of to what Adam's saying. I mean, for us, it's more about, I think this being a safe procedure around the world is more important than trying to,
Hoard knowledge.
Yes.
Yeah.
Hoarding knowledge has never made sense.
No, doesn't make sense at all.
yeah.
Yeah.
No, I think, I remember back to my training days, learning how to do ultrasound on lines. At first, yeah, it does add time.
Yep.
But then you've done a few, you've done a couple. It becomes so much faster. You become so much more confident in what you're seeing as you understand what the ultrasound's showing you. And then it's not slower. A lot of times it's faster.
Yeah.
Because you know exactly where you're going. You know the landmarks. You zero in, you see your image, and boom, you're there.
I was
So you're saying the pec blocks that Celebrity Anesthesia is doing is going to get under an hour at some point in the next couple of years?
At some point, man. At some point. We're chipping away at that time. No, I was going to actually echo your sentiment when I remember I was out in Western North Carolina in my training. We're at a VA, and we had a couple of anesthesiologists and CRNAs that were old school. I mean, these guys were like, 60, 70 years old. They had been there when there was no access to ultrasound. So, they're doing their 2 finger breaths above and this, and everything's landmark based. But, not everybody's body reads the anatomy book. And you guys know that just as well as I do. You get in there and you're like, whoa, these nerves and these arteries and these veins are not where I thought they were going to be.
I like how in your vignette about being in North Carolina, you didn't drop the D word.
What? Oh, I did go to Duke. For those of you guys listening.
You're welcome, Travis.
Thank you.
Those of you that listen that know that the wife and the school don't often not get a shameless plug.
Yeah. So and I was out in North Carolina with at your trendy therapist. Please give her a follow, and at your dementia therapist. No. But yeah, I completely agree. When they implemented moving to ultrasound and making that the standard of care for placing lines on the unit and placing lines when we would do hearts, the first 2 weeks, it was a little bit more cumbersome. We had an extra 15, 20, 30 minutes getting these patients to sleep and getting everything going. And then all of a sudden, it just became like rapid fire because it is like that little cheat code that you have. So I don't know. I think it's tough to adopt. It's just like computer charting or like any of the other things that medicine and healthcare have dealt with. After it's implemented,
yeah, I think we always need to ask the question: what would you do if it was your mom, your wife, your best friend?
Exactly.
And then you just have to decide how that sits with you.
Are you doing BBLs on your mom?
I'd argue at this point that ultrasound guided BBLs have really need to become the standard of care and the standard for safety these days, as we've seen more and more complications and deaths associated with BBLs. I think the answer to this is that we must use ultrasound these days.
That's how it starts, the standard of care. It starts small and it
starts
spreads.
small and it spreads. That's right.
It's kind of like with abdominal plasties. That was that was a procedure that was associated with deep venous thrombosis, and I
Yeah.
think many people now feel a lot more comfortable doing that procedure when they're using some degree of anticoagulation or at least SCDs after the fact. You know, I know I feel a lot more comfortable doing that once I had adopted what you do with the patients.
And I want to be fair to patients that are scheduled to get BBLs at other practices, and maybe they're not using ultrasounds. I also want to be fair in terms of like legitimate numbers, and please help me jump in with the stats and facts that you guys knew. One, the thing that makes it some hesitant for some plastic surgeons is, one, it is a process to incorporate this into your practice. You know, not every practice just has an ultrasound laying around. We used it for a lot of other stuff. So, you know, and then having some, new technology and everyone in our practice who likes new innovative stuff, I think that's made it easy for us. And obviously, so we're biased a little bit towards that. Two, I think, because even though we worry about these adverse outcomes are extremely rare. And
They
so
are,
to be
yes.
able to do a study and compare, people who've had it and don't, there have not, in all fairness, there's not been studies comparing ultrasound guided versus non-ultrasound guided using
That's
all
right,
these
yeah.
different methods in terms of, and that's some of the pushback, that's some of the fairness in medicine of, if you're going to take an evidence-based approach. I think this is more of a common sense approach to this versus evidence. I think for a lot of people it does make sense. So I'm just being a little bit of devil's advocate here
No,
in terms of
absolutely.
fairness.
We agree.
Do you think that might turn out to be like that little joke about there's never been a randomized prospective study of the use of parachutes?
Yeah, exactly.
Parachute versus no parachute. I think I'm gonna put my parachute on if I'm jumping out of the plane.
and exactly like you were saying about, if it was your mom, like for me, like after using the ultrasound, and when we first got it, I was like, hey, this seems like I've heard some people talk about it. I was like, I'm just gonna try it and see what it's like, and that's how we got started. Once I've used it, like for me now, it would be hard to go back because I just feel like the control that I have, the being able to visualize my own safety, but I also think even how I'm able to shape and sculpt the butt now when I can see exactly what I'm doing. I mean, it just doesn't even make sense to be, trying to do your artwork in the dark. I mean,
Yeah.
I know there's
Results are just
some
that much
fancy things
better.
like that, but yeah. Thoughts on that? I'm just trying to be fair and give the full picture here.
No, I agree. The rate of adverse effects is exceedingly low. But certainly when it does occur, it's close to home, and this is a small community of plastic. We are nationwide. We are a small community, and so this certainly hits close to home anytime this happens. But I agree. There are a lot of practices, of course, that are hesitant in implementing ultrasound. But on the other side, ultrasound over the years has really become very cheap to implement these days. The technology has improved, but overall, getting the ultrasounds these days are remarkably much cheaper. And like you said, it can be the size of your iPhone, a little bit bigger than your iPhone these days. It's not a big bulky thing like we all trained on.
And getting down to sort of brass tacks about it, how much is it going to cost if a practice wants to adopt this?
Honestly, you can get, most of us have an iPad or some type of smart tablet in our office already. And then an ultrasound itself, we get no financial benefits from them. We should. We use a Claris ultrasound, and I want to say it costs us about $3,000. So it's not a massive investment. I think it's just making the idea and saying like, hey, being committed to it, and is for people who are listening, and we have some more podcasts coming up on this. It's not just for BBL, but that we've adopted this. Some of you seen, watch us on Instagram. We've been doing this in the office. We have one in the office at all time in case we have any type of intravascular injection from a fascia filler, other stuff, which again is extraordinarily rare. We actually had somebody referred to our office that was done by somebody else in the community. They knew that we had this technology and used it, and were able to treat their patient for them and improve them actually quite rapidly.
Yeah, and even though these are rare events, the injecting into an artery within the face with fillers can lead to skin death. We've kind of avoided discussing what can actually happen with a BBL, but, there have been patients in Florida who have died. So these are never events that we're trying to prevent. So even though they're exceedingly rare, I think when you're thinking about how do you prevent a never event, $3,000 and a little bit of extra training and time in the OR for your first couple of cases probably is a pretty safe investment, a pretty good ROI. And, again, for anyone in Austin who's a plastic surgeon and who's doing this procedure and is not using ultrasound, again, I know that our practice would be very, willing and open to make sure that we can, if you feel like it's right, we can help education and experience not be an obstacle.
I feel like all of us have benefited from somebody teaching us, and so we're definitely not hoarders of knowledge and willing to share that with anybody.
Yeah.
Right.
Just because we're running a little bit on time, just from an anesthesia standpoint, really doesn't change anything you do.
It doesn't change anything. I mean, we still remain vigilant, and we're still looking for signs and symptoms of a fat injection intravascularly the entire time that we're doing the case, and that's kind of anesthesias. I mean, we always work as a team, so we're sitting there. If I ever notice anything weird or anything aberrant, I will immediately, hey, Dr. Weinfeld, hey, Dr. Franco, this is what's going on. And it's a nice song and dance, and we're doing that together. Outside of that, no, just maintaining, not keeping the patient relaxed or the muscle paralyzed while you're doing that. And then you are now adding one layer of protection or one extra layer of protection with the ultrasound.
Yeah. I remember, though, before we got the stand for the iPad, you had said you were getting sore shoulders holding the iPad. Like that was one of the issues. Glad that's better now.
Isometric workout.
Yeah.
It is a shout out to Nurse Ashley, who was holding it and jumped quickly on Amazon, and there was there. She put the kibosh to that quickly. We do a little segment called Behind the Bovie, and we alluded to this. I think one of the things that has changed this dramatically is, I know even when I was in residency, the ultrasound devices were these huge stand things, and honestly, I remember looking at some of my first ultrasounds and being like, WTF. Like, I have no idea what they're looking at. Like
a fuzzy TV.
Yeah, it definitely looks like our old TV with the antennas.
Ears.
And some of these new devices that, again, are the size of like our iPhones, that can be Bluetooth onto your iPad. It's amazing the quality of being able to see some of those structures. And I feel like in the world of plastic surgery, we're only scratching the surface of the technology, of the instruments that we can use that are only going to make things better and better. And people are like, oh, well, I thought you've already trained or learned this. I truly, truly hope that 15 years from now, my procedures are not exactly the same as they are today.
Right.
There's some version of them, but at least hopefully they're still
We hope
forward.
we're all evolving.
Well, that's the point of plastic surgery. It's a broad field, complex field. We operate in a lot of places, and if you stop learning, then you're not doing your patients a service. You want to give them the best cutting edge care that you can give them.
Completely agree with that.
Would you like to take us home with a little
Little quote of the day? Yeah, I got something lined
Without
up
Gilbert
for us.
here to
Yeah, I know.
We actually had a nice boys' day here. The team is doing some Morpheus in Mode symposium, so we got to have a little guy time here.
So I've got one from Steve Jobs. It says, for the past 33 years, I have looked at myself in the mirror every morning and asked myself, if today were the last day of my life, would I want to do what I'm about to do today? And whenever the answer has been no for too many days in a row, I know I need to change something. That was just related to, can we make things better? Yes. How can we make that change and make things safer for patients?
I think we all get trapped in the like, okay, I'm going to do this. I'm going to implement this. And we've all been victims of that. And I think it's just like, at some point, you just got to be like, today's the day. Let's do it.
Cut the cord and do it.
That's exactly right.
Well, I appreciate everybody. I think this was a super topic. We're definitely going to share more of it. I think we'll share some more videos, maybe some lunch and learns talking more about this topic, but it's nice to go in a little bit of depth. So appreciate having all of you here. Stay tuned. More episodes coming soon. Appreciate you guys. Follow us anywhere you get your favorite podcasts, iTunes, Pandora, Spotify, or if you want to see our pretty faces, you can check us out on YouTube. All right. We'll see you guys. Bye.
Thanks.